Hello, everyone. Good morning, good evening, and good afternoon, whatever you're joining us from. My name is Ibrahim Umar, and I am a member of the TP Recap Leadership Group. And today I'm very glad and honored to be facilitating this session, but I'm joined by my very wonderful colleagues, Anmo, as well as Sakit and Hans. They'll deliver superb presentations to you all today. And we'll be starting the show with Anmol. Anmol, the stage is yours. Please feel free to introduce yourself to the audience and share your presentation.
Thank you, Ibrahim. Good morning, good afternoon, good evening, everyone. My name is Anmolpreet Kaur, and I'm an international medical graduate from Punjab, India. I joined CB Solvers in 2023, and I have presented 3 TP recaps since then. But this has been long since I presented one, so this is my fourth TP recap. Very excited for this. I'll share my screen for my presentation. Is it visible? So I'll start with my presentation. The title of my presentation is A Delicate Dance Between Hormones and Electrolytes. So we will be basically recapping the presentation, which was on July 21st, presented by Alexander and discussed by Dr. Kirtan and Mark. Let's revisit the problem representation for one so that we can understand what we are discussing. This was basically a lady, 65 years old female, who presented to us with intermittent edema of the lower extremities, and that was happening since 2 weeks. So the past medical history was significant for 40 pack years of smoking and hypertension, which was controlled on tablet lisinopril, bipolar disorder, cerebral aneurysm rupture, complicated by strokes and seizures, which was status post-quelling. So there was extensive past medical history. And along with that, she also had COVID infection 1 year back, because of which she had baseline shortness of breath, which was associated with cough and wheezing. So there was a lot going on in her, and now since 2 weeks she was having intermittent edema of lower extremities. So what happened 2 weeks ago? She had trigger bites, and after which she had subjective sweats without fever and chills, and she also had intermittent palpitations, dizziness, and the edema of the lower extremities was associated with paresthesia as well. So this is what happened. And 2 weeks back, she also went to the ED. And in addition, she also started on these medications of tablet Lasix 20 mg once daily for 2 weeks. She has been taking this. Plus, she has been supplementing it with potassium 10 milliequivalents once daily. So this is basically the problem representation for this patient. And when we think about lower extremity edema, we mainly think about heart, liver, and kidneys. And in this case, we were mainly thinking about pulmonary hypertension because of two main causes. The two main causes were the COVID infection. COVID infection can lead to interstitial lung disease, which can cause chronic hypoxic respiratory failure and ultimately develop pulmonary hypertension. And also, this patient had such extensive smoking history, which raised the risk of COPD. So that COPD can also lead to pulmonary hypertension via called pulmonale. We all know that. So we were concerned about all these things, still thinking about heart, liver, and kidneys. What the lab showed to us, it showed that the lady was obese with significantly elevated blood pressure and 3+ lower extremity edema. That is very extensive. And then we also saw that the lady had oral thrush with neutrophilic leukocytosis. And glucose was 183 with HbA1c of 6%, normal LFTs, normal BU and creatinine, hypoproteinemia with normal albumin, hypokalemia with normal magnesium. And then because of the hypokalemia, we definitely can say that the ECG, the patient was in accelerated junctional rhythm with that severe hypokalemia. And the echo showed EF of 60% with grade 1 diastolic dysfunction with MR and TR, and BNP was 182. So if we go back, heart, liver, and kidney is normal. What about the heart? The heart, the patient could be having heart failure with preserved ejection fraction. That is quite common in the patients who have past medical history of hypertension, but still it does not explain that extensive edema. So there was something else, and we need to explain this hypokalemia and elevated blood pressure. This combination of symptoms of laboratory analysis made us think about some endocrine issues with her. So the aldosterone renin ratio was sent, which was normal metanephrenes, and normal 5-HIAA. Then TSH, free T4 were low, free T3 was normal. ACTH was sent, which was normal, and random cortisol was high. But then repeat testing was done and ACTH was found to be high and cortisol was anyways high. If you initially have high cortisol with normal ACTH, that is inappropriate, because if you have increased cortisol in body, that will give negative feedback to hypothalamus and pituitary gland, and that will decrease the secretion of ACTH. So this was inappropriately normal ACTH, and that was confirmed on repeat testing that this hypercortisolism was indeed the result of increased ACTH in the body. So, and one more good teaching point is that whenever we take the sample for ACTH, we need to take it, we need to place it right away on ice so that it does not degenerate and does not lead to abnormal values. And urine cortisol was elevated as well. Chromogranin A was elevated, indicating that there could be some neuroendocrine tumor. Liver ultrasound was suggestive of a hepatic mass, which was confirmed on phase CT that there was a mass. And then CT sella turcica imaging of the pituitary gland was done to evaluate if there is any primary cause of elevated ACTH there, but CT that was normal. And CT chest was done, which showed a left upper lung nodule, which was not evaluated further. And CT abdomen and pelvis was done, which showed some abnormalities in the stomach and the thickening of adrenal glands bilaterally. Ultimately, the liver lesion and the gastric lesion, they were biopsied, and this patient was found to be having invasive, well-differentiated grade 3 neuroendocrine tumor. So the active issues with this patient were persistently elevated blood pressure. This is the summary: persistently elevated blood pressure, persistently elevated blood glucose, recurrent hypokalemia, hypoproteinemia, significant anasarca, immunosuppression as evidenced by the oral thrush and the esophageal candidiasis, also with the hepatic lesion and the gastric lesion. All of this was actually explained by hypercortisolism, that was in this case due to ectopic ACTH production due to the neuroendocrine tumor. So if we actually want to go simply in this case, because sounds to be a very complicated case. So if we think about hypokalemia in general, then we have these CP solver schemas on the website. I think they're really amazing and we need to look them up. And if I summarize the findings of the schema, so hypokalemia, if we have the first thing, we have to understand if it is true hypokalemia, and we need to repeat those samples. And then we need to see if the patient is on diuretics or insulin. This patient was on diuretics, but still she was taking potassium supplement. That does not seem to be the cause. So either the patient is losing potassium through the gastrointestinal tract, or the patient is losing the potassium through the kidneys. And so if we want to rule out from the gastrointestinal tract, we need to see if the patient is having nausea, vomiting, diarrhea, which was not the case in this patient. Then we come over to the last bucket of renal losses. So renal losses can be divided into acidosis and alkalosis bucket. If the patient is having acidosis, then we think about renal tubular acidosis, specifically type 1 and type 2. And if we think about alkalosis, then we think about Barter's, Gittelman's, and inappropriate raised aldosterone or apparent aldosterone excess. So how does aldosterone basically lead to hypokalemia? Aldosterone, it promotes the sodium reabsorption from the distal part of the nephron. So when it reabsorbs sodium from there, there is increased excretion of potassium and hydrogen ions, which leads to hypokalemia and metabolic alkalosis, as is evidenced in this schema. So what can cause raised aldosterone? Again, we have a very good schema on the CP Solver's website. Inappropriately raised aldosterone. It can be understood from the interpretation of renin and aldosterone. If we have high aldosterone, high aldosterone, low renin, and low aldosterone, low renin. High aldosterone and high renin can occur in the cases of renal ischemia due to renal artery stenosis, and it can also occur in the cases of reninoma, that is a tumor of the juxtaglomerular cells. So in these cases, we have both high aldosterone and high renin. In the second case, that is high aldosterone and low renin, it is basically a case of primary hyperaldosteronism, in which we have adrenal adenoma or Conn's syndrome. An important thing to remember in this specific category is the presence of aldosterone escape mechanism. So aldosterone escape is basically, as we discussed, high aldosterone causes sodium reabsorption. So we expect the sodium to be high. But in these cases, aldosterone basically we have an escape mechanism so that we have normal net sodium and absence of overt edema. And it occurs because of pressure natriuresis, atrial natriuretic peptide release, and ADH release. And the last category, we have low aldosterone and low renin. So why are we saying that this schema is about inappropriately raised aldosterone? This is because in this case, the body assumes that the mineralocorticoid is high. There is an apparent mineralocorticoid excess, although in reality they are not high. So it can happen in Cushing syndrome, and it can also happen in other causes as well. And so if we have to now talk about the Cushing syndrome, which is basically a state of hypercortisolism. How do we define Cushing syndrome? It is prolonged increase in plasma cortisol, not due to physiologic etiology. And how it can occur, most of the cases are due to exogenous steroid use, and there are some other causes which can be due to endogenous overproduction of the cortisol. What are the main symptoms associated with it? You can have hyperglycemia. Our patient had hyperglycemia. Then you can have abnormal protein catabolism, and our patient had hypoproteinemia. So, and also we can have immunosuppression with the hyperglycemia. And then it also contributes to secondary hypertension in these patients. We can have weight gain, and neurocognitive changes and mood disorders are also characteristic. So our patient also had bipolar disorder. So we're not sure if that also can be attributed to Cushing syndrome. And there are some skin changes also which can occur with it, like facial plethora and purple striae that can happen with Cushing syndrome. So that is how I summarized how hypercortisolism caused all this thing. And about the significant anasarca, then there is a great explanation to it. Cortisol does not stimulate the mineralocorticoid receptors at physiologic doses. But when there is severe hypercortisolism, which can occur in ectopic ACTH production, it stimulates the mineralocorticoid receptors, causes the increased sodium reabsorption, water comes along with it, and hence it causes edema in the body. And by the similar way, it causes alkalosis and hypokalemia. And so basically, we can talk about the etiology of Cushing syndrome. It can be ACTH dependent or ACTH independent Cushing syndrome. ACTH dependent, that means ACTH is elevated too. So ACTH can come from either pituitary or other parts of the body. If it is coming from the pituitary adenoma, then we call it Cushing disease. If it is coming from the other part of the body, it can come from non-pituitary tumors like small cell lung carcinoma and bronchial carcinoid. Mostly they are neuroendocrine tumors. And then we have ACTH independent causes. That means it is independent of ACTH. ACTH won't be elevated in these cases, only cortisol is elevated. So it can directly come from the autonomous cortisol production from the adrenal adenoma, or it can come from the exogenous glucocorticoid therapy. That is basic etiology of Cushing syndrome. And if we talk about our patient, she was not taking glucocorticoids. She was not having any pituitary adenoma. She was not having any adrenal adenoma. We imaged all of that. This patient was having ectopic ACTH production. How do you diagnose Cushing syndrome? I think this is the most important slide. The cortisol levels varies throughout the day. So basically, the first you have to confirm hypercortisolism. How do you do that? Check 24-hour urine-free cortisol, late-night salivary cortisol, and do a low-dose dexamethasone suppression test. If we do that test and check cortisol the day after, if the cortisol is elevated, then that confirms hypercortisolism. So if we confirm hypercortisolism, then the next test is morning 8 a.m. to 9 a.m. corticotropin levels. If these levels are elevated, that means we are in the category of corticotropin dependent hypercortisolism. If they are not elevated, then we are in the category of corticotropin independent hypercortisolism. And if we are in the category of ACTH dependent causes, we'll do a high dose dexamethasone suppression test to differentiate between the two categories of ectopic ACTH production and Cushing disease. So if the suppression is there with the high dose dexamethasone suppression test, it is likely pituitary adenoma, and if there is no suppression, it is likely ectopic ACTH production. Then ultimately towards the end, we can talk about the association between the neuroendocrine tumor and Cushing syndrome. So we can say that they are a relatively rare and heterogeneous group of neoplasms, and they originate from neuroendocrine cells. What are the main sources of neuroendocrine tumors? GI tract, pancreatic tract, lungs, thyroid, and adrenals. And paraneoplastic Cushing syndrome can represent approximately 10% of all Cushing syndrome and is frequently caused by neuroendocrine tumors. So how do you treat it? It is basically, we again have those classification of ACTH dependent and ACTH independent. So if the Cushing disease is there, that means the patient is having pituitary adenoma. So you can go for transpenoidal resection of pituitary adenoma. If the patient is having ectopic ACTH, then that means there is some source of ACTH in the body other than the pituitary gland. Then you can do a surgical removal for that. But if you cannot remove it, you can also give medications like ketoconazole. And then we have corticotropin independent causes. Adrenal adenoma, if the adrenal adenoma is itself secreting the cortisol, then we can do surgical adrenalectomy. And if it is exogenous Cushing, then we can gradually taper off glucocorticoids. So these are my references. And at the end, I just have a question for the audience. Can we straight away taper glucocorticoids, or what is the need of gradually tapering glucocorticoids in these patients? I have this question, and thank you very much. That's the end of my presentation.
Great presentation. Thanks, Anmol, for taking the time to build up this presentation and present it to all of us. You can even look at the chat. There are multiple people who were truly impressed by the classic way of presenting this diagnosis while also, presenting all of these clinical information in such a short time frame. So moving on to our next presentation for today. Saket, please feel free to introduce yourself to the audience and start your presentation.
Hello, everyone. Wonderful presentation and more very comprehensive. Uh, so I'm an ECFMG certified from IMG as well. I'm one of the recent CP Solvers Academy members. And just a second, I'm going to share my screen. Can you guys see it? Okay, perfect. Okay, so I'm going to go to a very second. Yeah, okay. So I'm going to discuss a case that was actually presented by one of our beloved Academy members, Eugene, on the 25th of July. And it was discussed by Dr. Rabi and Prof. S. It was a case of a 22-year-old male who presented with severe left leg pain. So this is going to be a bread and butter case. So I'm going to quickly do a case recap of the initial presentation, and then focus more and try my best to focus more on the disease itself. So we had a 22-year-old man who presented with essentially two symptoms. One was the acute symptom, which was the inability to walk due to severe asymmetric swelling and pain in the left leg. And the second symptom was more subacute to chronic, which was a 1-month history of progressive bilateral lower limb edema, fatigue, and anorexia. So what did the exam and lab show? So the exam revealed tenderness and swelling of the lower limbs with normal vitals, and the lab showed raised inflammatory markers and a low serum albumin. So further imaging confirmed that there was a DVT in the left lower limb extending from the popliteal vein to the iliac vein. And additional labs also revealed massive proteinuria, hypoalbuminemia, and hyperlipidemia. So a unifying diagnosis of nephrotic syndrome was made here, which explains both the chronic edema that the patient had and also the hypercoagulable state that precipitated the limb-threatening DVT that he ended up presenting with. So the reason I chose this case was because most of the exposure that I've had to nephrotic syndrome was during my pediatric rotation in my internship, where the presentation is more or less very obvious compared to what you see in adults. Children present with like puffiness in their eyes, ascites, anasarca, some lower limb edema, and you initially have a very high suspicion of nephrotic syndrome, and you end up like recognizing it pretty early and starting them on steroids, sometimes the very next day itself, versus adults who present with more indolent symptoms, sometimes more chronic symptoms. And it's important to recognize that and treat it. So just to quickly recap the diagnostic criteria of nephrotic syndrome, which underwent a slight change in the year 2021, 2022. So KDIGO sort of defines it as nephrotic range proteinuria, more than 3,500 milligrams in 24 hours, along with a serum albumin of less than 3 grams per deciliter, along with extravascular edema. This triad should essentially prompt you to think about nephrotic syndrome in your top differentials. Some associated features that can also be seen are hyperlipidemia and lipiduria. Uh, Adults usually present with all these three, and that should prompt you to label someone as nephrotic syndrome versus a child where nephrotic range proteinuria is essential, but they can have either hyperalbuminemia or edema to label them as nephrotic. Now, I have a question for the audience. Is all nephrotic range proteinuria nephrotic syndrome? Feel free to unmute, or you can just drop an answer in the chat. Okay, so yeah, perfect. You got it right. So yes, all nephrotic range proteinuria is not nephrotic syndrome, and there are a host of other reasons that can cause nephrotic range proteinuria. The most common ones being diabetes mellitus, secondary FSGS due to sickle cell disease, obesity, and all of the other causes as well, hypertension, and also amyloidosis. So, and it's important to remember these because these cause nephrotic range proteinuria, but they don't get severe enough to cause hyperalbuminemia and extravascular edema. So it's important to keep the whole clinical context in picture before going further with treatment. Now, why do you get hyperalbuminemia in nephrotic syndrome? The reason we all know is the urinary loss of albumin, but another reason to keep in mind is blunted compensation by liver as well. The edema that you have in nephrotic syndrome is primarily extravascular, which is popularly explained by something called the underfill theory, where because of hyperalbuminemia, you have loss in the capillary oncotic pressure, leading to a decreased effective circulatory volume, which causes salt and water retention, primarily in the extravascular space, as opposed to the intravascular space edema that you see in nephritic syndromes, where you have classically the beta hemolytic streptococci that releases plasmin. And this plasmin goes and activates the ENaC channel in the nephron that causes rapid influx of salt and water. And so the rapid influx there causes hypertension as opposed to edema. That's just an important point to keep in mind. Now, why do you get hyperlipidemia in nephrotic syndrome? So these patients have loss of HDL in the urine. There's decrease in LPL activity, which causes an increase in triglyceride levels in the vessels. And also they have an increased LDL synthesis by the liver. But it's important to keep in mind that this hyperlipidemia doesn't need to be treated at all, and it usually resolves with treatment or remission. And because it's such a temporary and transient process, there is no risk of atherosclerosis. So why are we so worried about diagnosing and treating nephrotic syndrome? Or if I had to rephrase it, what is the one or two complications that you're really worried about with patients having nephrotic syndrome that you want to diagnose and treat it immediately? You can just drop the answer in the chat or. Exactly. So the real issue with nephrotic syndrome, I like to remember two things. One is thrombosis. The second is dangerous extravascular edema. So a serum albumin of less than 2 directly correlates with a higher risk of thrombosis in these patients. And why do they have it? Because they have loss of antithrombin 3, they have loss of protein CNS, there's increased platelet aggregation, increased fibrinogen, and decreased plasminogen. All of these collectively contribute to a high risk of thrombosis. And they can have thrombosis in various parts of their body. They can have a PE, a DVT like our patient presented with. They can have cerebral vein thrombosis, renal vein thrombosis. So make sure you keep a watch on all of these stuff. Another feature is dangerous forms of extravascular edema. I like to keep these three things in mind: pleural effusion, pericardial effusion, and ascites. So think about two scenarios in a patient who has been labeled as having nephrotic syndrome. Now, this patient presenting to you with disproportionate dyspnea in the right clinical context, make sure you get an echo to rule out a pericardial effusion. The same patient with ascites and abdominal pain, though you usually don't tap a nephrotic syndrome ascites in a child, but make sure you rule it out if you have a very high suspicion of peritonitis. Now, just some numbers that I was able to get from the literature with regards to thrombotic complications in adults. The overall thrombotic risk is much higher in adults compared to children, and that's just an important thing to keep in mind, which is around 25% compared to 3% in children. And surprisingly, arterial thrombosis is much more commonly reported in adults compared to the pediatric age group. And some other numbers that you can see regarding DVT, pulmonary embolism, and renal vein thrombosis as well. Now, what are the primary differences in nephrotic syndrome between adults and children? Adults present with a varied etiological spectrum, and they usually require a kidney biopsy for diagnosis of nephrotic syndrome, which was seen in our case as well. Versus children who usually have, usually need a biopsy only when we are suspecting that they have a secondary cause or they're not responding to the treatment that we give them. Adults usually have a lower baseline kidney functional presentation, and you can see the mean eGFR values versus children who have a better preserved kidney function at disease onset. And just to make a point, there is absolutely no need to have an abnormal RFT to diagnose nephrotic syndrome. Patients with nephrotic syndrome can present with a completely normal RFT, so this is just a piece of information. And in adults, it's important to make sure you rule out secondary causes in the right clinical context again, because all of these can also cause nephrotic syndrome. You can have patients with malignancy, Hodgkin's lymphoma, hepatitis A and B, infections essentially, patients with Sjogren's also presenting with nephrotic syndrome. So make sure you rule those out when you have a suspicion of that. Some of the key takeaways from the entire presentation, I tried to summarize it to the best of my ability. Make sure you work up an adult presenting with very subacute sort of indolent symptoms, with like symptoms of negative nitrogen balance, which seems like malabsorption, liver disease, endocrine disorders. Also, make sure you get an UA. It's a very simple, practical test, easy, low cost. Rule out nephrotic syndrome. Thrombotic complications are more common in adults, so have a high degree of suspicion. And also keep a lookout for manifestations of dangerous extravascular forms of edema. Thank you so much.
Great presentation, Saket. I honestly loved the presentation. I loved how it was a bread and butter case, yet you could, just because I am gonna assume everyone has seen this presentation before, I'm absolutely 100% sure that everyone who's attending this session today got something out of your presentation. So thank you so much for the time and the effort that you took into presenting this topic. Moving on to the last presenter, last but not least, for today, Hans, the floor is yours. Please feel free to introduce yourself to the audience and share your presentation.
Okay. Yes, my name is Hans, and I just have to get my presentation up. Just a moment. There we are. So my presentation for today goes back to July 24th. This was a patient, 66-year-old, presented by Luke Miley, and the case discussions were Rabi and Nicola. It was, in my opinion, a very fascinating case of a 66-year-old female with a past medical history. It was significant for chronic kidney disease, type 2 diabetes mellitus, and she presents with shortness of breath for 3 weeks and 2 months of diarrhea. Now, of greatest concern for us at this stage was her shortness of breath for 3 weeks, as this can be life-threatening. And then we had diarrhea as a second disease, with the question that arose, are the two may be related or not? And for those two diseases to be related, we expect their trajectory to be common. That is, possibly that diarrhea and shortness of breath or any such symptoms occur roughly at the same time and evolve in the same way. We shall refer to this question at the end. It is the question of Hictum dictum and Occam's razor. Let's see how it evolves. The patient's history of present illness included a slowly worsening shortness of breath upon exertion, and the patient actually admitted that she is no longer able to climb stairs. So exertion was a problem for her, and the diarrhea, according to the patient, was non-bloody, it was watery, but she also admitted to a weight loss of 10 pounds, and it was unintentional. Family history, social history, etc. was unremarkable or not relevant for the case itself. So what are we thinking about a slowly worsening shortness of breath upon exertion? What happens when patients are in a position where they find it very difficult to do some work like climbing stairs, physical work? And the first test that we can do upon our physical exam is to walk the patient. And that is exactly what we did. We walked the patient with a pulse oximeter, and we noticed that at rest, room air, the patient had SO2 of 97%. Upon exertion, however, the oxygen saturation fell to 85%. And the first conclusion out of there was there is somehow not enough oxygen reaching the bloodstream. And oxygen goes in through our bronchial upper airways, and then the lower airways, and then the alveoli. And everywhere along this path, is it possible that the patient gets out of breath? And the inefficient oxygenation, if we can rule out stridor, which is evidently easily to be heard, would be that there is an alveolar capillary membrane impairment. Is there an obstruction in the airways? Our physical exam will show probably something in the lungs, some music in the lungs. Another possibility would be, is the blood flow impaired? But under these circumstances, if we have, let's say, right or left heart failure, there is backup of blood into the lungs. And again, the lungs are being affected from the heart. If we can expect the patient to be anemic, then we should have a normal SO2 during rest, and if at the very most, a slightly decreased SO2 upon exertion. So no finding as this one. Our physical exam showed a notable dullness upon a palpation in the right lower lung field with diminished breath sounds. And the conclusion out of there was, are the alveoli filled with fluid or cells, or do we have a pleural effusion? So percussion, dullness upon percussion is highly suspective of pleural effusion. And just these findings with virtually very limited resources and doable everywhere, stethoscope and palpation already lead to the conclusion that we will come up next. The vitals, which is also very interesting to notice. So a blood pressure cuff we also needed. The patient needs a high heart rate, and that was our conclusion of a heart blood pressure, which is pretty much normal, heart rate 110. So the conclusion here was, does the patient need a high heart rate to maintain an adequate blood pressure with sinus tachycardia? And the possibilities that arise from there is our heart constrained? So it's an ordinary mechanical constraint on the heart, like pericardial effusion, like attention pneumothorax, which could explain the patient's shortness of breath, but it would also come with pain, and it would be fairly sudden, not as insidious over 2 weeks. Then we have attentional pleural effusion as another possibility, and that would definitely also explain the dullness upon percussion. And this could also compromise the cardiac output and lead to a high heart rate with a normal blood pressure, as well as a compression of our alveoli and shortness upon exertion as noticed with the patient. At this stage, we already can come up with a differential that might include, considering the age of the patient, 66, her unintentional blood loss, unintentional weight loss as being lung cancer, maybe a mesothelioma, which could show with a pleural effusion, and lung metastasis, maybe from the colon, maybe a neuroendocrine tumor, a carcinoid tumor. That could explain the diarrhea, but we would kind of expect the two to come together in time course. The diagnosis was almost clinched by looking at the CT. First CT abdomen, which cleared the abdomen completely. The patient was up to date with all her cancer screenings and there were no findings. Liver, colon, everything clear. Ovaries, clear. Next was the CT chest, and that was where the money was. She had extensive nodular thickening of the pleura, right-sided diaphragmatic lymphadenopathy, and a pleural effusion as suspected from the physical exam. And then the thoracentesis was conducted and the patient had immediate relief. So we have a nice, simple, mechanical explanation for the patient's chief complaint, except for the diarrhea. The thoracentesis with biopsy of the pleura gave the result of an exudative pleural fluid with high-grade neuroendocrine carcinoma cells. So this is then a high-grade neuroendocrine carcinoma cell, which I will explain later on, in no likelihood is not hormonally active. It's a highly aggressive, difficult to treat malignancy. I have one more remark, and I think that's a really interesting one that Ravi mentioned. Peritoneal and pleural fluid can be oxidative even in the absence of inflammation or cancer, that is, in the absence of cytokines, which make our vessels leaky. And these can be fistula, such as a pancreatic pleural fistula, where we have pancreatic fluid in the pleural space, or simply urine causing ascites from a cystic peritoneal fistula. I thought this remark is really interesting just to notice. I want to conclude similar like Almond Bread with a brief overview of what are neuroendocrine neoplasms. Neuroendocrine neoplasms, as mentioned in the first session or case, originate from cells of the neuroendocrine phenotype. They can occur in every organ system. So we have the gastropancreatic system with 70%, the respiratory system where it can occur, but there I have to add that most of the neuroendocrine neoplasms in the respiratory system are of high grade, non-hormonally active, and only a few are hormonally active. Other sites are not so important with 5%. Now we have a dichotomy of our neuroendocrine neoplasms. We have the well-differentiated neuroendocrine tumors, the NETs. These are our carcinoids. They are giving rise to diarrhea, as in carcinoid tumors. They are gastrinomas, they are glucagenomas. All of these produce hormones. They are well treatable, oftentimes with surgery, but sometimes we just do observe and don't treat. And then we have the poorly differentiated, highly proliferative neuroendocrine carcinomas. And these are either small or large cell carcinomas. The World Health Organization classifies them according to a protein that is present in actively dividing cells. It's the Ki-67 index. It is high, over 20% for the poorly differentiated NECs, and it is lower than 20% for the well-differentiated. So basically what we have when we look at our neuroendocrine tumors and the dichotomy, we have a stem cell and we have a committed stem cell towards a neuroendocrine destiny, but it's not well differentiated. If it then differentiates well into a hormonally producing cell, it can become malignant later on and become a neuroendocrine tumor or carcinoid. If it becomes malignant and proliferates aggressively at a less well differentiated stage, then we get our neuroendocrine carcinoma. And now we have the different tissues in our body where we can see those tumors, and it's either the neuroendocrine cells from neuroectodermal origin, and we all are familiar with them. It's a paraganglia secreting adrenaline and noradrenaline. The paragangliomas, the pheochromocytomas, and the neuroblastomas. Interestingly, it can also occur in the nose as olfactory neuroblastomas. But the epithelial origin that we have in our case can either be the gastrointestinal tract and the pancreas, our carcinoid tumor, the bronchial system with the more serious ones, thyroid and parathyroid, and pancreatic islet cells. This one, yeah, that's basically my presentation for today. And that is a diagnostic journey, not an easy one, of a 66-year-old female with a past medical history for CKD, type 2 diabetes, with subacute progressive shortness of breath, 2 weeks, intermittent non-bloody diarrhea for 2 months. Imaging showed a pleural exudate, extensive nodular thickening, and a biopsy result gave us the diagnosis. Thank you very much. And that is a mountain in Switzerland. Thanks for the opportunity.
Thank you so much, Hans, for today's presentation. So I'm not sure if you've been taking a look at the chat, but I 100% agree with what Ala mentioned here. I think everyone can build a presentation, but to make it simplified and to actually make it practical in a sense that you explain every slide that you go through is just a different level of masterclass. So thank you for today's presentation, and thank you Anmo and Saket as well for engaging us and for teaching us so much from cases that had been presented on CPS before. Before we end today's presentation, I just wanted to let everyone know that we have a neuro VMR happening after this VMR. It's starting in 15 minutes. So if you have the time, please show up to that as well. Otherwise, we're going to see you on another Teaching Point recap session. Thanks, everyone, and have a great day. Bye.